Hello, everyone. So I'll be presenting on snake bites in Cameroon, and this will be first results of the evaluation of the Inoserp Pan-Africa antivenom. Snake bites are a neglected problem in the world. According to the World Health Organization, globally more than 2.5 million snake bite envenomings, 130,000 snake bite deaths occur each year. Sub-Saharan Africa accounts for more than 20,000 of the annual snakebite deaths. In 2019, Chofo and collaborators reported a mortality rate of 2.5% in Cameroon. The high mortality and morbidity from snake bites may be due to limited options for antivenom globally. The asterisk on the map indicates the global distribution of antivenom manufacturers, and we can notice that there is none in sub-Saharan Africa. Sanofi stopped production of Favafric in 2010 due to its high cost of production. The limited treatment options are compounded by limited access to antivenom for snakebite envenoming, a neglected condition that affects mainly poor people. The cost of snakebite treatment is high, reaching as much as $100 to $200 per dose. Even when and where care is accessible, the snake causing the bite is usually not identified. Furthermore, each bite is different. For example, where on the body it happens or the amount of venom injected. These factors present challenges for case management. The World Health Organization, in its updated recommendations on antivenom for snake bites, advised the use of TABG in sub-Saharan Africa. This is effective, especially in the case of envenomations caused by Echis ocellatus, otherwise known as the carpet viper, which is the most reported type of snake envenomation in this region. The TABG is not yet included in the Medicines Sans Frontières guidelines for snake bite management due to lack of sufficient data on safety and efficacy. The antivenom serum from Inosan, called Inoserp Pan-Africa, is currently being used in sub-Saharan Africa, including Cameroon. However, limited data exists on its efficacy or tolerance in our setting. Accordingly, we designed this study. Look at the objectives. Our main objective was to estimate the short-term clinical tolerance of the Inoserp Pan-Africa antivenom serum, but we also sought to describe the clinical profile on admission of patients with snake bites, and also to estimate the death rate caused by snake bites in Cameroon. The next slide will show you how we went about it. We did a pharmacovigilance study that included consenting patients, 5 age and above, who consulted for snake bites in any of the 14 hospitals included in the study in 6 out of 10 regions of Cameroon. The inclusion sites were on a rolling basis in both the north and the south sites. We excluded patients treated with an antivenom prior to admission for the current snakebite episode, and patients who reported a previous confirmed severe allergic reaction to antivenom serum. The antivenom was the same throughout the study. We used a standard protocol for administration of antivenom, that is, 2 vials for hematotoxic or cytotoxic syndromes and 4 vials for neurotoxic syndromes. We will be looking at the study now. On admission, patients without signs of envenomation were followed up for up to 4 hours, during which, if they did not develop any signs, they were discharged. A follow-up visit was organized at the participant's home 15 days later, mainly for geolocation and examination of the bite wound. If during follow-up, the participant developed signs of envenomation, they were transferred immediately to the second arm. Signs of envenomation were administered antivenom. The time of administration was considered H0. At H1 and H2, evaluation were done to see if there was abatement of signs or symptoms of envenomation and or occurrence of adverse events. Required, a participant was administered another dose of antivenom, and the monitoring followed with H2 prime, representing 1 hour after the new administration. They were then followed up for at least 3 days, discharged, and a day 15 rendezvous organized. In the following slides, we present the first results. Difference in gender in our study. The median age was 23 years, and children 24.1% population. 25.1% of the study participants were farmers. 46.6% of the study population had received care before arrival at the study hospitals. 83% of these were visits to traditional healers. Here is a participant who was unfortunately bitten on the head by a snake. She presented with a swollen face and periorbital edema and a poor clotting test. The median time from a snake bite to admission was 4.9 hours. From arrival to first antivenom administration, 30 minutes, and from the snake bite to first antivenom administration was 6.5 hours. The body side most reported for snake bites was the feet, as 56.6% of our study population were bitten on the foot. Admission, the majority of participants, that is 321, presented with cytotoxic syndrome, followed by hematotoxic syndromes in that order. The most implicated snake was the carpet viper, also known as Echis ocellatus, which is in concordance with what was reported by Shippo and was in 2019 for Africa. The average number of vials administered per patient was 2.9. Some patients received as many as 12. Adverse events were reported amongst 21.6% of participants, with 82.1% of these being mild to moderate. Most frequent mild to moderate events, tachycardia, and bradycardia. A total of 12 severe adverse events, all of which were deaths, occurred. However, the Data Safety and Monitoring Board declared that none of these deaths were related to antivenom. No serum sickness was documented, and this could actually be due to a limitation of our study design, especially given participants were discharged after 3 days and only seen again 50 days. Mild to moderate adverse events were anticipated and mentioned in the investigator's brochure. On the next slide, we will provide more details on the 12 deaths. Of these participants were from the north side. The mean age was 29.6 years, and the mean delay to administer antivenom serum amongst those who died was 129.8 hours. And most incriminated in these deaths was Echis ocellatus, with a good number of the participants presenting with a hematotoxic syndrome. So, this study provides the first safety data of Inoserp Pan-Africa that is currently being used in sub-Saharan Africa. The Inoserp serum appears to be well adapted and tolerated in our population. We recommend antivenom related, and hospitals are not the first care site chosen by populations affected by snake bites. These results are preliminary safety results from the study and could reopen discussions on Inoserp while hoping the efficacy results are satisfactory. We also recommend that traditional healers should be an integral part of management of snake bites in our setting. You remember the participant on slide 7? This is a picture of her 2 days after administration of Inoserp Pan-Africa antivenom. Thank you.